This week on the BackTable Podcast.
I say, you want to improve your erections? You want to reverse ED? You want to be able to have sex until the day you die? Your sex span as long as your life? You want that? This is what you do today. I have a much greater chance of him doing it than if I said, hey, you got diabetes, and it's a much greater chance of him listening. And I will use that ticket over and over again to improve his quality of life moving forward. So I think we are very unique in that we have a condition that people will listen to and are more motivated to make those lifestyle modification changes.
Hey folks, my name is Amy Pearlman. I'm a board-certified urologist, and I am your host today for today's episode of the BackTable Urology Podcast. And I have one of my most favorite people in this entire world with me, Dr. Mohit Khera from Baylor College of Medicine. Mo and I go way back. I was at medical school at Baylor College of Medicine from 2008 to 2012. And I didn't know it at the time, but Mo would become one of the greatest influences in my career. We got to work on some research together at that time, looking at men who had been given testosterone with a history of prostate cancer. And what fun work that was. So Mo is a professor of urology at Baylor College of Medicine. He's a director of the Laboratory for Andrology Research, and he holds the Brantley Scott Chair in Urology. Mo, it is so great to have you with us today.
Amy, thank you so much for the invitation. And I have to say, and I'm not just saying this, you were one of the best medical students we've ever had at Baylor. And you wrote the seminal paper on testosterone and prostate cancer. I'm very proud of you. In 15 years, you've come a long way. And I'm just so proud to see your trajectory.
Oh my gosh, you're so kind. I remember back in the day when we had paper charts. So I would go in on the weekends or after hours, and I would go into the medical record area, and I would sift through the charts, and I was looking for all the PSAs that I could find on these patients. Research is done a little bit differently now, but it was such a good learning experience.
Great ride.
So today's topic is going to be talking about therapies really beyond this little blue pill. And our audience are going to be mostly urologists. And so pretty much everyone listening today is obviously going to be familiar with therapies like Viagra. So I want to go beyond that and really keep evidence in the background, but I really want to pick your brain because you have a very busy practice at Baylor. And I want to pick your brain about some of the maybe off-label uses of medications that you're using, how you're combining therapies, and perhaps most importantly, what are the 10 to 30 second, snippets of information that people listening can start telling their patients starting today to optimize some of these therapies. So how does that sound, Mal?
That sounds great.
All right, awesome. So let's begin. We know that PD-5 inhibitor medications are going to work in a large majority of patients, but they don't work in everyone. And they may not be as efficacious in men who have low testosterone. Now, looking back to my days when I was a student at Baylor, I remember very vividly you were giving a grand rounds to the department and you were talking about testosterone, transdermal formulations, and I was blown away. I was like, this guy is a rock star. And I remember sitting in that room as a medical student. So you are one of the most outspoken people when it comes to testosterone. How does testosterone play a role in the efficacy of PD-5 inhibitors?
Yeah, so much to talk about, Amy. So let's talk about testosterone first. So we know that testosterone has been used and first synthesized since 1935. So it's been around for a long period of time. And if you look, testosterone is so important for overall erectile function, in preventing cavernosal atrophy, helping with improving the efficacy of PD-5 inhibitors. I was very fortunate. I was on the 2018 AUA guidelines for ED, and it is true. We said that testosterone should not be used as monotherapy for erectile dysfunction, but we still put it in the guidelines because it works phenomenally in combination therapy with PD-5 inhibitors. So I'll give you an example. A man walks into your office, he's hypergonadal, you start him on Viagra, it doesn't work. If you start him on testosterone supplementation, the literature would support that 30 to 50% of non-responders will become responders to PD-5 inhibitors by putting them on testosterone as well. So that's in the guidelines, that's in the AUA guidelines, and that's why we do it. Now, do I think that testosterone as monotherapy can be effective? I do in certain populations. Certainly for patients who have very low starting T levels and they can, like say, 200, 150, they'll see a dramatic increase as well. Patients with mild to moderate ED, I do think it makes a significant difference. And I do think that if patients who don't have a significant number of comorbid conditions, that'll throw you off. So there is some benefit, but yes, testosterone is very important for overall erectile function. And clearly it's why we check it also in men. It's in the guidelines who present with ED.
So is any man presenting with ED, is he getting his testosterone level checked?
No question. No question are they getting their testosterone level checked. Now look, ED is a marker of poor health. Let's be honest. It's a marker of cardiovascular disease. It's a marker of depression. There's no question. And depression is also a marker of diabetes. So by very nature, men who present with ED are more unhealthy. But in the same token, testosterone is one of the best barometers of a man's overall health. For example, a man with low T, no question, increased risk for cardiovascular event. That's in the AUA testosterone guidelines. Low T is a marker of increased risk of having a cardiovascular event. Low T is a marker of obesity and diabetes. Low T is a marker of depression. Low T is a risk factor for bone fractures. And we know in the literature, low T is associated with, I'm not saying causing, is associated with prostate cancer. The lower T, the more likely to have prostate cancer. So you show me another blood test on the planet that has more association with more comorbid conditions. It's not your lipids. It's not your thyroid, Low T. So every man, I believe, over the age of 40, every man should have a testosterone level checked once a year. It is a best marker of overall health and your future overall health.
Mo, I was recently at the gym and I was listening to you on a podcast. That's like my favorite thing to do is I'm at the gym. I'm either listening to you or Dr. Morgenthaler on a podcast on YouTube. And you made that comment. If there's one test that you would want to get checked in a man, it would be his testosterone level. Is it ever too early to check a man's testosterone?
Why not? We know that levels decline with age, and sometimes it's not the absolute, but the delta. Men starting out at 800 level and you drop them down to 350. Yes, he's still normal, but the delta can be an issue. And every man has his own set point. Maybe mine is 350, maybe someone else is 450. That's why I find it ridiculous that we have this number 300, and at 290, everyone must feel bad. At 310, everyone must feel good. That's not what happens, right? We all have our own number. And so sometimes I think that some patients have a higher number to be at where they tend to see symptomatic improvement. So the big mistake is a man comes in at 250, I start him on testosterone supplementation, I take him to 400, and he says, I still have symptoms. You have two options. You can say, well, you're normal, so something else is going on, or raise them even higher, still in the normal range, to see if there's some benefit, right? I mean, that makes more sense to me. Maybe his set point is 450 or 500, and so we need to raise him higher to a higher level. And I think that many men, at least 30% of men, if you just raise them to the upper quartile of normal, you can salvage someone who's not responding to T to have someone who is responding. So again, be sensitive about the fact that not everyone has the same number.
Are we failing young men as a healthcare institution, like the guys who are in their 20s and 30s? Are we failing them by not getting them into the office and checking these baseline levels?
Yeah, so I love this question. And Amy, this is something I'm very passionate about. I think we're failing them in a different way, and let me explain why. When I was 30, if you asked me to go in and get my blood pressure checked, there's no way I'd do that, just annually. If you asked me to go get my hemoglobin A1C checked, there's no way I'd go in for an annual checkup. But if a man gets erectile dysfunction today, a young man, he is at my door first thing tomorrow morning. He's ready to talk about it. It's like, what is going on? This is horrible, right? They come in, right? And there have been numerous very impressive studies looking at young men. One of them came out of St. Louis, ages 18 to 40, finding that when the men came in for ED, 30% on the spot were diagnosed with diabetes or prediabetes. That's pretty impressive, 30%. And there's this concept called area under the curve, which means if I catch your diabetes at 30, or I can't catch it at 40. The 10 years I would have waited to catch it at 40 is 10 years of damage that occurs to the vessels and to the body. 10 years. That's a lot of damage. So if I catch it at 30 and intervene, the trajectory of your life, health span will change, right? Trajectory, right? So catching it early. What is the biggest mistake that urologists or a lot of my colleagues, all of us do it, and I'm just as guilty when I started my practice. The biggest mistake is to hand them the Viagra and say goodbye. That is the mistake, right? And that's what 99% of us do. Like, okay, here's your Viagra, erections are going to be fine, let's go. And not intervening, looking for cardiovascular disease, diabetes, or even intervening on lifestyle modification. If I say, Mr. Smith, you're 28 years old, you got ED, But let me tell you something. If you improve your diet, exercise, sleep, and stress reduction, you will significantly have an improvement in your erectile function. He's going to listen. He's going to listen to me. But I'm secretly improving his health span and his lifespan as well, right? But the mistake, again, is I hand the Viagra and say, hey, we're all good. He says, yeah, we're all good. And he leaves. That's a problem.
So a little bit off topic, but certainly related to your field with you directing the andrology lab, should we also be offering semen analyses for these young men for baseline information?
Yeah, you're hitting another important topic. As I mentioned to you, that I think that testosterone is one of the best barometers of a man's overall health. I can tell you so much about a man's health with a testosterone, and the same goes with the semen analysis. You look at our colleagues, Mike Eisenberg, beautiful paper showing that semen analysis, if a man has a poor semen analysis today, it's a predictor of future cardiovascular events, comorbid conditions. That's a predictor, and it was very strong. So if you have a poor semen analysis today, I can tell you in the future that you may have an increased risk for diabetes, metabolic syndrome, and having a heart attack. Another one of our colleagues, Tom Walsh, showed a great paper showing that if you have poor semen analysis today, it's a predictor of cancer, prostate cancer in the future, testicular cancer has been shown as well. So it's well known. The nature of the land is this fertility is a marker of overall health. More healthy you are, the more fertile you are, right? And the more unhealthy you are, the less fertile you are. That is how it works. And it's a predictor of future health. So I think that getting a semen analysis is an excellent way of predicting future health. Now, it's a lot easier to get a T level, than just check semen analysis in men, but I agree with you. It's a wonderful window into a man's overall health is a semen analysis.
Yeah, I think one of the things that we as urologists need to learn too in order to make this more accessible is which are the therapies that maybe patients could do at home to make it a little bit more cost effective, especially for the young man who may not have an issue, but wants to at least do some sort of screening test or baseline. Do you use any at-home technologies for semen analysis
Yes,
testing?
so Fellow is fantastic. I mean, you've seen that also. They're a great
and I
company.
use them as well.
Yeah, they ship the kits. You can ship it back. It's a lot easier. Some men are very uncomfortable leaving a semen analysis in the office, right? So it's a little more difficult. They can do this at home.
Can you believe that we still have people do that?
People do that. I mean, sometimes,
know.
particularly when you're in the office for a visit, if you have your semen analysis connected to your office, then it's very easy, and they can do it right there, and you usually get the answer within 30 minutes, so it's fast. But you're right. I mean, but Fellow does help with it, making it discreet. It's more comfortable. You can do it at home, and it's a nice window into your fertility, but also, I believe, your overall health. And getting a testosterone level checked. These two tests are not expensive. Do you know what I mean? And they do help predict overall health.
Love it. All right, so let's kind of dive deeper into this PD-5 medication bit here. So you mentioned the man who comes in, he's a young guy, he gets a prescription for Viagra or Cialis. What if he doesn't have an issue? Let's say he's coming in for a well man's visit. That doesn't really exist, but what a beautiful world it would be if it did. And he's curious, hey, I heard that my friend takes Cialis as a pre-workout at the gym. Can I get a prescription? Can we hurt that guy?
Yeah, I'm just not a big fan on using it for off-label like that. I'm not. I do think that you should have some indication for using the medication. But the indications for daily Cialis are far beyond just ED. I want to take a step back and just talk about one thing. If, for example, a man breaks his leg, I have two options. I can fix his leg, or I can give him Vicodin. Because if I give him Vicodin, he can still walk until the Vicodin will no longer work, and then we have even a bigger problem. The issue is Viagra is Vicodin. It is not a cure for ED. I'm not curing his problem. I'm masking it for that night, and as it gets worse every single day or year after year until he now needs an injection or an implant, right? So that is a big problem. That Viagra is not a cure. To me, though, there's certain things on the planet that are a cure. We've talked about diet, exercise, sleep, and stress, and there's great data on each one of those we can get into about how each one of those actually independently can reverse erectile dysfunction. But the other drug that I am very sensitive about that I think is fantastic is daily Tadalafil. Daily Tadalafil in numerous studies have shown to cause increased hypertrophy of the cavernosal smooth muscle. So I tell the patient, if I told you to go to the gym and lift a dumbbell every day, what happens to your arm? It hypertrophies. I said, if I give you daily Cialis, the same thing's happening to your penis, right? It actually makes a benefit. So that daily 5 is far more important to me than that 20 Cialis on demand. Far more important. Then some patients say, well, I don't notice much. I say, I don't care. It's going to be healthy. It's going to protect you. And if a man is predicted to have ED at, say, 65 years old, I feel like the daily Cialis shifts the curve to maybe 75 years old, right? It'll shift the curve. So that's very important. But now it gets even more interesting. We know that it's FDA approved for BPH. How awesome. I mean, these conditions run together. The part that I am most excited about is that we know it's FDA approved for pulmonary hypertension. And we know that there's excellent data that it preserves the endothelial lining, the endothelium. And endothelium is a systemic effect. It's not just in your heart. It's everywhere in the body, right? So I know that I'm protecting the lining of the blood vessels. And to me, I think it's cardioprotective. Cloner last year showed a 13% reduction in MI if a man took daily Cialis, 13% reduction and 25% reduction in mortality. So now you got my attention. Cardioprotective, BPH, ED, one drug that's now generic and it costs $20 for 90 pills with a GoodRx coupon card. It's almost a no-brainer. I mean, to me, that is really important.
Yeah, I'm on the same boat as you. I love that medication. It's what I call vitamin C. Are you using it all for like performance enhancement? I had some guys who said, hey, I'm taking this for other reasons. And I notice that when I time it before a workout, I get more of a pump at the gym. So I actually have some of my patients, and full disclosure, this is not on label, right? This would be off label use. But I do have some patients time their medication before they work out and they get a better pump at the gym.
Yeah. I've heard of it, Amy, I've heard of it, but I just have not prescribed it for that indication. I've heard people say when I work out, it may be better, or some when I go to higher altitudes, but I just haven't seen the data. And so I'm just reticent to go there yet. That's all,
So Mo, you're doing some really interesting research using the Tech Ring by FirmTech at Baylor, and you're using it in men who are on testosterone therapy. Can you talk a little bit about the role of this device in testosterone patients?
Yeah, this is a great invention. So remember that historically we used to use MPT testing, and that is very archaic in how we would measure a man's erections and how long they would last. But now we have the FirmTech, which Bluetooths automatically to a man's phone, and you can get incredible real-time data, how long the erections they are, how rigid the erections are, how often they get the erection. And what's amazing is that you can do any intervention you want. You can give drug X, you can give drug Y, you can give testosterone, and look at the before and after on the FirmTech. And it gives you a wonderful data on how well that therapy is improving. Remember, men get anywhere from 3 to 5 erections every night. And you want to then see if they're getting these nocturnal erections and how rigid they are. Great piece of information. But flip it, not only is it a great research tool, it's great to prevent venous leak. It's the same instrument, the same band that we've been using for decades to help. Because again, remember, most of ED is venous leak. And how do we as urologists treat venous leak? We try to overcome it by increasing the inflow. That's what we've always done. I tell the patient, hey, your inflow is 10, your outflow is 15, so why don't we increase your inflow to 20? That'll work. Or use a FirmTech and decrease the outflow, right? And that's a very effective treatment. What's nice about FirmTech, a lot of patients like, is that it's not a drug. It's not a pill, right? And it doesn't cost every time you use it. You've already bought it, right? And so there's a benefit in cost and in terms of safety, I think.
So if we go back to our earlier discussion, which is what are the things that a young man should know about his body? We spoke about testosterone. We spoke about a semen analysis. And now we're talking about erectile fitness. Maybe this is like the triple cocktail for young men to get them engaged in their bodies, in the healthcare system. And perhaps what you so eloquently talk about all the time, the 4 things that are responsible for lifestyle modification to improve overall health. Like, how do we get people to change behavior? We give them data and we track it before and after.
Yeah. I think you said something very important. So look, and I follow Peter T. He had a great book that came out, Outlive, and he talked about medicine 2.0 and 3.0. And the reality is that what we do today in medicine is reactive. I'm going to wait for that heart attack and I'm going to put you on a cardiac diet and heavy exercise. I'm going to wait for that diabetes. I'm going to put you on metformin and I'm going to try to decrease your diabetes. And that's a mistake. That means our healthcare system waits for the problem and then tries to treat it. And that's what we do for sexual medicine. We wait for the ED and then we treat it. And then the ED gets worse because our treatment is just a Band-Aid on a problem. And then we go to the injection and the implant. Wouldn't it be great if you met the patient 20 years earlier, somehow, before they had the ED, and we started something that would prevent the ED from happening in the first place? That would be ideal. It's idealistic, so maybe that can't happen. But I do look at the patient presenting with mild ED who asks for Viagra as exactly the patient who presents who gets a hemoglobin A1C and it's 5.9. He's pre-diabetic. He's sitting there. You have a couple options. Now, you can start with lifestyle modification in that pre-diabetic and get that hemoglobin A1C below 5.7. And the same goes for that guy you're giving Viagra to. You can either help him now and help him reduce the ED with lifestyle modification, which does work, or you just let the ED and the diabetes get worse and you kind of treat it when it goes on, right? And that's what we do right now. We just give him the Viagra and say, call me when it stops working. And start the injections, call me when it stops working. Okay, let's go to the implant. That's our model. That's the model we do today, right? It's very archaic. We know that lifestyle modification can work. We knew that some of the regenerative therapies have a tremendous amount of promise as well. So I do feel like it's important to be proactive about your sexual health as opposed to just being reactive and waiting till the problems get worse.
Whose job is that to have these conversations?
It's our job as urologists, I think, is to educate the patients on this natural history that's going to occur. I mean, I think we are the leaders in the field, right? We are what we call the experts in sexual dysfunction. And I think that we have an obligation to educate, right? And I know we are all under time constraints. I get it. And it's tight. But with modern technology, there's ways to make handouts, videos, social media. There's ways to educate besides face-to-face now. You know that. I mean, you know that better than anyone, And so I think that's very important. But I still think that the system is designed to say, you got ED, here's your pill, I'll see you later. That's how the system works right now. And let's one more thing, Amy, women, we are the experts in male sexual dysfunction, but we have an ability to actually be experts in female sexual dysfunction as well. And I know you have a good interest in this as well. It is very important. Remember, it is not about that patient, that male patient sitting across from you in the exam room. It's also about his female partner sitting at home. And it is a disservice to skyrocket his libido and skyrocket his erections. And he has no one to have sex with except some woman at home that's going to be miserable and fighting with him every day now because things were great before he met me, right? So you got to be very sensitive to what are you really trying to accomplish.
Yeah, Mo, I'm so glad you brought that up. And it's interesting because, yes, I'm a woman, but I've been treating men's health for much of my career. And it wasn't until a couple of months ago that I took Dr. Rachel Rubin's course and learned how to do female sexual medicine. And I had so many male patients that were coming in and they were saying, hey, I feel great. My libido's great. My wife doesn't want to have sex with me. Can you help her? And I was tired of telling them no, because the reality was I could. I just needed to learn how to do it. I think that's another message maybe for people listening is we're already doing the things. All the medications that we're currently using in men, I mean, I use a lot of medications off-label in men like Addy, like PT141. I know you use those medications too. They're approved in premenopausal women. And I realized, oh my goodness, now I can just use these medications on label for these women that historically I didn't think I could help. I'm embarrassed to say this. As a woman, I didn't think I could help women. Isn't that terrible?
But it's easy and you can. And you know you can. Because I know you've been doing it now. And it's unbelievably easy. You're right. You can use the same medications, even testosterone. If you can manage, you can prescribe testosterone for men. You can actually prescribe it for women. It's unbelievably effective, particularly when it comes to HSDD or low libido. Very effective. Yes, Addy, bremelanotide. You can use it in men, but you can also use it in women on label. So we're already doing it. And I will tell you the satisfaction of improving both sexual functions is far greater than improving just one. The amount of good that you're creating is far greater when the couples come in and say, wow, on both sides, you've helped us both. That's where the magic starts. It's not just about just improving one partner's sexual function.
Mm-hmm. So you were mentioning the great benefits of the low-dose daily Tadalafil in men. How about in women?
Great point. I have not seen data, but I do use Tadalafil or Viagra in women for arousal disorder, right? As she says, I have decreased arousal, decreased blood flow to the genitalia, decreased lubrication. Men and women are not so different. It works for arousal. So if she has arousal disorder, we use PD-5 inhibitors. If she has libido issues, I use either Addy, bremelanotide, or testosterone. I like testosterone. I like Addy a lot also. So I have medications for each one. Even now, there's data to suggest that these Addy can help with orgasmic dysfunction, right? That was published in one of the ISWISH meetings as an abstract that, orgasmic, and we don't talk about orgasmic dysfunction, but that's a big problem. When we talk about in men or women, delayed orgasmia or anorgasmia, where's the treatment? Where's the there's no
It's to see a
treatment.
sex therapist and to teach the patient how to have sex. That's what the guidelines state.
Like, what do we do? So we have to, use medications, be creative. And we published a very sad story. I had a 28-year-old gentleman who had anorgasmia, primary anorgasmia, which means he never had an orgasm in his life. We tried many things. We published this last year in JSM. We gave him many trials, but we used off-label ADE, and ADE was helpful. Again, this is off-label. Just want to stress that, but it did make his first orgasm. So I think you have to be creative in sexual medicine. You do, because there's always not going to be this textbook answer of what to do, and you have to be creative in deciding how you're going to help the patient.
Yeah, if I were to think of the most challenging patients that I see in my clinic, it is the men presenting with delayed ejaculation or reduced sensation, and we really don't have any good therapies for them. So let's kind of dive a little bit into the, ADDI and the PT-141, because that's where I'm using a lot of these medications off-label in men. So the guy comes in with erectile dysfunction. When might you add one of those medications to, let's say, their Tadalafil regimen?
Yeah, so I think those medications are more effective, particularly for libido, right? I think it makes a difference. I do think that if you look at a man who put him on, I always go with testosterone first. I also think it's important to optimize the erection, so daily Cialis. Remember that a man with ED will sometimes come in and say, I have low libido. And the reason I have his low libido is because, think about it, it's 10 o'clock at night, he's exhausted, and he knows that he can try to have sex, and it's a 50% chance it'll work, but if it doesn't work, he's going to be frustrated. Or he can go to sleep. Well, he's going to go to sleep, right? Because it's just, he has to deal with it, right? And he keeps doing that over and over again. And he thinks, oh, he's got low libido. She thinks he's got low libido. But in fact, he's just doing something called conscious aversion. He's just avoiding sex because he doesn't want to deal. But let's say you take that same man and you give him these most amazing erections every night when he goes to sleep and these amazing erections every morning when he wakes up. You know what he's going to do? He's going to use them because it's there. Right? I'm just going to tell you, he's going to use them. And then he's going to say, my libido went up, right? And the reality is your libido went up because your sexual function significantly improved. That's why your libido went up. And so optimizing erectile function is important, then optimizing hormonal function. And remember, it's not just T. We teach the residents the mnemonic PET, prolactin, estrogen, thyroid, testosterone, PET, P-E-T-T. So if someone comes in with low libido, check the PET, right? And make sure that nothing else is going on. So if you do that and you optimize lifestyle modification, because fatigue and stress will shut down libido too, right? If you're tired or you're stressed, sometimes you're not willing to engage. So optimize lifestyle modification, diet, exercise, sleep, and stress reduction. Then if it's not effective, okay, what else do I got? And that's where I start crossing over to ADDI. I like ADDI a lot. It's a simple medication. And the concept is very similar. It just increases dopamine. If I increase dopamine and norepinephrine in someone's brain, they're going to want to have sex. That's what it does. And that's why we used to give Dosinex. That's why we used to give Wellbutrin before this came out. We were very creative. We'd use anything that would increase dopamine would increase the desire for sex. So there are neurotransmitters that are excitatory. There are neurotransmitters that are inhibitory. So serotonin is going to bring me down. Dopamine is going to bring me up. And so we just tried, and melanotide, bremelanotide, melanocortin is excitatory. And so all we're trying to do is increase the positives above the negatives to induce desire and orgasmic function.
I'm glad you brought up those other medications. You didn't mention oxytocin, but I know we've used oxytocin before for some of these reasons. And then Virgiline, Dosinex, like you mentioned. So are you ever using those medications anymore, or are you just going right to a medication like ADDI?
I'm going right to a medication called ADDI only because I have found it to be somewhat more effective. But I will tell you that the problem with this is that there's no magic bullet. I tell the patient, I'm going to start with ADDI, but I may have to go to Wellbutrin, then I may have to go to Dosinex. I may have to go to Himbine. I mean, there's a lot of things. There's no magic bullet. So I'm going to start here because I had a little bit more success with this one, but this may not work. And then we're going to have to go to something else. And do not forget, Amy, the most important part is you have to ask about with masturbation. If the guy says, well, with masturbation, I have no problem with delayed orgasmia, you're done. This conversation's over. This is psychogenic until proven otherwise, right? And if someone says, oh, with masturbation, the erections are fantastic. Well, you have situational ED, you have situational delayed orgasmia, and situational means that the hardware works perfectly fine when you're alone, which means it's psychogenic, right? And that's where you want to see the sex therapist. Now, many men are reticent to see a sex therapist. I get it. But now, most of the sex therapists, we have 3 of them, they all do Zoom. You can do it from your home. It's more private. You don't have to walk into the office. But question the masturbation with delayed orgasmia and ED. It's a very important question.
So follow-up question to that. Is there a role for using any of these medications to overcome the psychogenic component? Or is the only solution seeing a sex therapist?
No, so this is a great question. So when a man has ED for the first time, particularly let's say it's a young man, okay? He has ED. Do you know what he does when he has sex the next time? As he's having sex, he's saying, I hope I don't get ED. I hope I don't get ED again. He's saying this to himself. Well, guess what's going to happen? The second he says it, he's going to get ED again, okay? Now it's happened twice. Now he's even more freaked out. Now sex becomes anxiety provoking. Now he's getting nervous that he may get ED again. Is it going to happen? Is it not going to happen? And it becomes an issue. The same thing happens with delayed orgasmia. As a man's having sex, he's like, why is it taking so long? And you know what that happens? They get frustrated as they're having sex. Well, guess what? You get frustrated, you're not going to orgasm, right? So that's an issue. So we call it the vicious cycle. It's a vicious cycle. And one of the best ways, particularly for ED, to break the vicious cycle is put them on a daily PD-5 inhibitor. Because if you put them on daily PD-5 inhibitor and they notice that every time they're having sex, they're having these great erections, they get more calm. And I tell them, we can always take the PD-5 inhibitor away later or wean it down. But they don't want to later. They like it. But essentially, I just need to show them 10 out of 10 times that their erections are phenomenal. They're amazing. And guess what? They tend to do great. They tend to say, okay, this is fine. Another tool is a penile ultrasound. If I get the penile ultrasound, they come to my office and I say, Mr. Smith, your penis looks fantastic. The blood flow was 40 milliliters or centimeters per second. There was no end-diastolic leak. You have great blood flow. Sometimes that's also therapeutic. They just want to know, like, oh, I'm so glad. Nothing's wrong with my penis. Erections are fine. So it's very important that there are other things you can do besides a sex therapist to reassure that patient that things are good.
So you had mentioned before that you were using the tech ring, at least in the research study. How do you decide if you're going to have someone use a tech ring to monitor their nocturnal at-home erections versus a penile Doppler?
I think that both are good. Some have to do with just age and how technology savvy they are. Young men are pretty good with tech rings and they know what they're doing. Some of the older men say, I don't want to really wear this every night and do it to my phone. And I say, it's a case-by-case basis. But I do think that the tech ring is very valuable. We are in an age where we are monitoring everything. Many people have a Whoop. They have an Aura ring that's monitoring their sleep. I use something called an 8 sleep mattress cover. I love it. It monitors sleep. I use a CGM, a continuous glucose monitor, on myself and many patients. I want to know my glucose. Well, the tech ring is just the same thing, but erections. You can use these devices to learn more about your behavior and how it affects your health in a positive or negative way. And then you can change your behavior to mimic more of the positive results, right? And that's all it is. That's what a Whoop is. That's what a CGM is. That's what a tech ring is. And I think there are going to be more and more coming out of monitoring ourselves. And so it's just another tool. And patients do change behavior if they're given data. I've seen it over and over again. They will change behavior if they're given data.
What's some technology that you hope that comes out so that you could track something of interest? Like, what would you like to track? Is there anything else that comes to mind?
Well, I would love to have the ability to check real-time hormone levels in the body. And I know that technology is being worked on right now. So you could see real-time where the levels are, where they're being changed, how they're being affected. And not just testosterone. I would love to see other hormones being checked as well, real-time. So I think that would be fantastic. There's other technology for ED that we're not talking about, but we didn't talk about radiofrequency. I think it's a very important concept. Radiofrequency has been around for a long time where we use it on the face, right? So in the face, there's type 1 and type 3 collagen. If I use radiofrequency, I tighten the type 1 and type 3 collagen. Well, if you look at the penile anatomy, what happens? We get a venous leak because the tunica albuginea becomes loose. We call that the drum. I tell the residents, the drum is loose. I can't push the muscle against the drum. It's not taut, and you're going to get a venous leak. Well, radiofrequency will tighten type 1 and 3 collagen. Well, guess what that tunica albuginea is made of? Type 1 and type 3 collagen. So maybe if I tighten the collagen, I will prevent the venous leak, and that's another way to do it. So I think that's an interesting technology. Full disclosure, we're one of the 3 sites in the country doing that technology, but I think it's something to keep an eye on because everything we've talked about in terms of treatments, besides Firmtech, is a mechanism to increase inflow, right? So theoretically, shockwave increasing inflow, Viagra increasing inflow, in penile injections, increasing inflow. But the answer is really preventing outflow. And that's where the FirmTech comes into play. It's preventing outflow. And that's where I think the radiofrequency may come into play. We're preventing outflow. That I think is really important.
Awesome. You mentioned radiofrequency. You're currently doing clinical trials on it, or you're offering it for patient care?
No, clinical trial. So I'm using a device called Vertica, which is a home device where the patient will take the device home and use radiofrequency 3 times a week for the first week, 2 times a week for the second week, 3 times a week for the first month, 2 times a week for the second month, and 1 time a week for the third month. And it's a randomized placebo-controlled trial, so half the patients are getting placebo. But initial studies out of Israel, when they did not do placebo, did show significant improvements as early as 4 weeks. And a significant improvement in IIF, those 8 points, very quick. So I think there may be something into it. I don't want to jump the gun. I think it still needs to be in study research protocols, but I think it has potential. And basically, Amy, because it does address venous leak, I think.
When can we expect some of those preliminary findings? That sounds fascinating.
Yeah, I think it'll be towards the end of this year, but I do think it'll be very interesting. I do think it has some potential.
What else gets you excited in the ED space?
Well, mostly, to be honest with you, the most excitement I have is the lifestyle modification. You know, last year, it does take a little bit of counseling, but I just feel like the amount of benefit that patients can benefit from are far greater than the pill we can give them. You know, last year we published a very large series looking at exercise. So you know if a man exercises 40 minutes 4 times a week at just moderate exercise, we see a significant improvement in IIF scores. That's on 40 minutes 4 times a week at the 6-month mark, you see a significant increase. The greater the ED you start out with, the greater the jump in IIF scores, almost up to 5. That's just with exercise. Look at diet. So Esposito showed Mediterranean diet, prospective trial, and then she's also done it in women as well. Putting them on a Mediterranean diet or no Mediterranean diet at all, showing that that diet alone significantly improves IIF scores in men with no other intervention, right? It's just diet. And so that is in your hand. Sleep, we looked at sleep as well. If someone sleeps less than 6 hours a night, it significantly increases your risk for ED, no question. It also increases your risk for being hypogonadal because remember, in the hypoxic state, if you're hypoxic, you have less LH secretion, which means you'll have less T, right? So sleep apnea puts you at a risk as well. If a patient slept 7 to 8 hours, a significantly improved erectile function. And some patients would say, well, if more sleep is better, if I sleep 12 hours at night, will that really improve my erections? And the answer is no, because the study plateaued at 9 hours. So you can't sleep 10 or 11 and expect more. But 7 or 8 hours, I think, will have benefits. So think about it. And in stress, I mean, it is a big deal. We don't talk about it, but stress significantly impacts sexual function and hormone levels. Lately, I've been doing a lot of work with the U.S. military. I was in Tampa at the SOCOM database talking about a concept called operator syndrome. What is operator syndrome? It's when our military are going through extensive training. When they go through extensive training, they get a significant reduction in testosterone levels, and that testosterone level can stay reduced for weeks after they stop the training. But that's physical stress. I mean, that's a tremendous amount of physical stress, which can have an impact on hormone levels as well. So that area of lifestyle modification to me is extremely exciting. I think it not only impacts someone's health span, but it impacts our sex span as well. It's very important. And so I think more research really should be in that area.
It warms my heart for you to talk about lifestyle modification, especially coming from, just the past president of the Sexual Medicine Society of North America. And people, think of you as a very busy surgeon, which you are. And yet the thing that you are most excited about is lifestyle modification. And so much in our training, I mean, even when we go to really great places, as residents, we don't want to be in clinic. We want to be in the operating room with a scalpel in our hands. And yet first-line therapy for every condition we treat is lifestyle modification. But what we don't learn in training is how do we educate our patients in a way that inspires behavioral change?
Yes, but guess what? That's your ticket. People will listen. If a band came in and he says, hemoglobin A1C of 5.9, and I'm, primary care doc, I said, look, you really need to improve your lifestyle modification because I don't want you to get diabetes. I don't know if he's going to do it, but we are so privileged to have a condition that is eye-opening and captures your patient's attention.
A sexy condition to modify behavior.
Amy, they will listen. They will listen. Not all will listen, don't get me wrong. But I say, you want to improve your erections, you want to reverse ED, you want to be able to have sex until the day you die, your sex span as long as your life, you want that? This is what you do today. I have a much greater chance of him doing it than if I said, hey, you got diabetes, and it's a much greater chance of him listening. And I will use that ticket over and over again to improve his quality of life moving forward. So I think we are very unique in that we have a condition that people will listen to and are more motivated to make those lifestyle modification changes.
We are so lucky. To summarize what you just said in terms of lifestyle modification, so for the people watching, if they say, well, I don't have 30 minutes to just, neither do you have 30 minutes to have this discussion, but really the key take-home points are 40 minutes, at least 4 times a week of moderate exercise.
Yes, that's easy. So that's an easy thing to say, right? About 7 to 8 would be ideal, but it's at least 7 hours of sleep. That's an easy one. That's easy. 3, you can say the Mediterranean diet, but it has just simple qualities. Just saying foods with low sugar and more antioxidants. That's all you got to remember. So decrease your glycemic in the pastas and the breads and any of those kind of things. Decrease the glycemic index and more antioxidants in your body. Blueberries and kale and things that you can do. That in itself, that was unique to the Mediterranean diet, but that's not the only diet that does it. So that a little bit, and then decreasing your stress. And stress is easier said than done. We all live in a very stressful environment. So, but just acknowledging that you have. So I always just say to them, tell me about your stress. Is it high, low, or medium? That's all I'm asking. And they'll give me a number, high, low, or medium. And then I'll say, okay, as long as you acknowledge it and it can address it, it's very important because most people have to think about it. And because they don't think about their stress level. They just kind of do their thing. Acknowledge it. If it's high, make some changes because it's a secret killer. And so make the adjustment. So those are simple things you can do today to get started. And remember, you and I, everyone listening to this, all of us can do better on diet, exercise, sleep, and stress reduction. And if we all just chose to focus on one of them today, it would have a profound impact on our quality of life, right? So imagine all of them.
I love it. Now, for people listening, where can they find more information? Because you've been on this busy podcast circuit, which I absolutely love, with really, well-known podcasters. So maybe that's could be an exit strategy for a busy urologist, is saying, I acknowledge that, sleep and stress and nutrition, and exercise are all really important. It's a little bit out of my expertise, or we don't have time to discuss today. Why don't you check out this podcast? What are some of your favorite podcast episodes that you've done?
Podcasts are excellent. Well, backtrack 1 second. Have a referral source. I have the most amazing nutritionists. I have 2 of them, and I refer them all the time. They say, I don't have the time to go through all the diet modifications. I can give you the overview, but this is who you want to see. I do hand them a chart of the Mediterranean diet. It's a pyramid, and you can just hand it to them, and it shows what in moderation. So the red meat once a month, right? And then more fruits and vegetables at the bottom. And it's a very nice picture that they can take with them. And I can say there are other diets. This may not be the right for you, but go see Tammy Carney, who's one of the best functional nutritionists, and they go see her. So that's great. So that's very important. Having someone for exercise. I have 2 people that I will use that offer exercise and counseling, and will even do workouts with the patient. So you just have to have the resources. You don't have to be the person doing it, right? That's a really important point. Having the resources and having the spoke mainly. I use the sleep lab probably more than anyone I know at Baylor, because a lot of these patients have sleep apnea for ED. They have a cold sleep apnea when their hematocrit goes up on T. And if someone says, I have chronic fatigue, fix my T, I say the reason for chronic fatigue is not T. It's you're not sleeping well, And so you're going to go get a sleep study. And you're not going to have to sleep in the sleep lab anymore like the old days. They'll give you a machine. You can sleep at home and do it. And that makes a big difference. So I'm not counseling on the sleep, but I am making that referral. And that's what I think is very important. Use your local resources and get up a spoke, each one of these, and for your practice.
I love that. So what are some of your favorite recent podcasts that you've been on?
I like listening to Peter T. I think he's fantastic. He really knows how to break it down. I like Gabrielle Lyons. She's really good about muscle fitness, and she's spot on. Louise Newsom has a great podcast on testosterone. I think she's great. Diary of a CEO, phenomenal podcast. I mean, really inspiring, and the way he gets down to the detail and gritty. And I like Huberman. I think Huberman has a very good, excellent podcast. Just kind of, I like the way they break it down to the basics and the fundamentals.
Yeah. The one last thought that I want to kind of leave on is we talk a lot about frailty in our older urologic patients and how some of these medications we prescribe, like antimuscarinics, may not be good in that patient population. It sounds like we are part of the solution to preventing frailty.
Yeah, so it's multimodal, but the reality is, people say he's getting very old. Testosterone could be dangerous in the older patient. I say, on the contrary, that patient needs it more than anyone else. You want to prevent sarcopenia. You want to prevent bone fracture. Now, the preventing bone fracture has not been shown yet. I mean, it's been shown that men with low T are increased risk of getting a bone fracture. We're in an era now of candidate, and we're still studying it. But you want to use the medication. I think it helps with cognition. I think it helps with depression. A lot of these are symptoms of men as they get older, right? And so this is and I don't want to have people think if I give T, it solves those problems. I want you to think that if I give T, I can help in conjunction with doing other things. So giving a man testosterone and having him lift weights is really the answer to preventing sarcopenia, and taking in protein, right? So 0.7 to 1 gram per ideal body weight, you want to make sure you take in the protein, because if you don't have the protein, then that's going to be an issue too. So protein, lifting weights, testosterone, I think, is how we prevent it.
Dr. Khera, where can people find out more information on you and your practice?
I mean, we have a website. I like to put out a newsletter as well. It's drmohitkhera.com, and I try to keep it up to date, and I think it's a great resource for people. I also think the SMSNA website is phenomenal, smsna.org. You can get incredible data and information on that website, and they have a lot of good videos as well.
Awesome. Last question for you. What's next? You were just the president of the SMSNA. What's next for you?
I'm writing a book on sex ban. So it'll be out by 2026, and working on it every week. And that's my next big thing.
Yay. We'll have to interview once the book comes out.
Yeah. Excited.
Thanks so much for your time today.
Yeah. Thank you, Amy. Great to see you.
Likewise.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, DM us at _BackTable Euro on Instagram, LinkedIn, or X. BackTable is hosted by myself, Ruchika Talwar,
Jose Silva,
and Suzette Sutherland.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe DeGrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz.
Thanks again for listening, and see you next week.